You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for May 14th, 2021. This week, COVID, an ACC Preview, Polypharmacy, Finerenone, and ethics. First up, of course, is COVID. I'm going to be very brief. It's getting better. We are almost there. I renewed my passport this week. Let's move on to the ACC. It starts this weekend, as in tomorrow. Here are a few brief comments on the trials that I see that are most potentially interesting. Now, I always miss some, but these are the ones that stand out. The first trial to be presented is Paradise MI. It's one of those big multi-center industry-sponsored trials that compared sacubitril valsartan to ramipril in post-MI patients who had both an EF less than 40% and clinical evidence for heart failure. The trial also required having one risk enhancer, such as age, greater than 70, or AFib, or diabetes, or prior MI, etc. Now, there was no run-in phase. That enhances the trial's generalizability, and depending on dosing, ramipril is a pretty legitimate comparator. Again, though, I do not understand why these trials are not designed to just compare sacubitril valsartan to valsartan alone. Especially in this case, because we know that in the Valiant trial of post-MI patients with LV dysfunction done many years ago, event rates with valsartan were essentially the same as captopril, which had previously been shown effective against placebo. Now, shortly before ACC, Novartis announced in a press release that although numeric trends favored sacubitril valsartan, it did not meet its primary endpoint of reducing cardiovascular death and heart failure. So my friends, at ACC, you're going to have to pay close attention to this presentation. Quote-unquote, numeric trends favored the drug, but it did not reach statistical difference. I've published previously on the presence of spin in the cardiovascular literature. I'll link to that paper. I'm pretty proud of this collaboration. Spin occurs when trialists emphasize something other than the primary endpoint. That said, we can't just discount data that misses an arbitrary boundary of 0.05. In fact, this is where Bayesian interpretation of trials can help. You can ask, what are the probabilities given the data of, say, a 10 or 20% benefit under, say, pessimistic or enthusiastic priors? Now, speaking of priors, as I wrote in my preview piece, the highly marketed drug sacubitril valsartan is now 1 for 3 in big clinical trials. Recall that in heart failure with preserved ejection fraction, sacubitril valsartan did not reach statistical significance against, wait for this, valsartan alone. Its only win in Paradigm HF was against the medium-dose ACE inhibitor enalapril. I wonder what would happen if we repeated that Paradigm HF trial with equal dose valsartan as the comparator. Finally, there is another reason new therapies in cardiovascular medicine have trouble. Baseline therapy is better and secular trends show declining event rates. And when event rates go down and baseline therapy gets better, it's harder to show differences in new therapies. That's sort of a good thing. This is likely why the 3 primary prevention trials of aspirin that were published in 2018 did not show a net benefit, whereas historically they had been beneficial. Now, speaking of aspirin, we'll also hear the results at ACC of the Adaptable trial. Adaptable is a truly pragmatic trial comparing 81 versus 325 milligrams of aspirin for secondary prevention. That is, to prevent another cardiac event in patients who already have established coronary artery disease. The trial will feature quite special methods in that patients were enrolled and followed with a direct-to-patient randomization and data collection will be using a novel web-based patient portal format. Now, 81 versus 325 is an important question. If there is no difference in efficacy, say and/or bleeding, and the trial's methods pass muster, then we can just go with the lower dose. We're going to have to pay attention to this methods question, though. The next big trial, LEOS 3, in my opinion, is probably one of the best at ACC. This compares left atrial appendage closure at the time of heart surgery versus no closure. Now, these were patients with AFib who had to undergo cardiac surgery for coronary artery disease or valvular heart disease or some reason. Now, surgeons love to clip that thing off, but to date, no one knows if it helps. Observational studies of this have been fatally flawed. In fact, I have made slides of some of these observational studies because they depict near-perfect examples of selection bias. LEOS 3 authors have published a rationale paper, and I love it because it is a simple trial that has a simple outcome, stroke or systemic embolism. It's so refreshing not to have to parse out a bloated composite endpoint or complex randomization schemes. It's closure or not, and you count up the strokes. The most important thing to remember about this trial is the study question. Does appendage occlusion reduce stroke in addition to baseline therapy with anticoagulation? This is a totally different strategy and question that percutaneous left atrial appendage closure deals with. Remember, in the device trials, in the Watchman versus warfarin trials, ischemic strokes were actually higher in the Watchman arm. This means the only benefit, if any, from this endocardial device comes from stopping anticoagulation. I look forward to this Canadian-led, non-industry sponsored trial. Next up is an SGLT2 inhibitor study. The ACC will feature an important meta-analysis involving the novel, yet-to-be-approved drug sotagliflozin. This is an SGLT1 and 2 inhibitor. Deepak Bhatt will present the effects of the drug across the full spectrum of ejection fraction, including heart failure with preserved ejection fraction. Now, Dr. Bhatt is on the record as saying, quote, "I think sotagliflozin has the potential to be best in class." The drug class of SGLT2 inhibitors does seem amazing, but we also heard in a pre-ACC release of the DARE-19 trial. This was an RCT comparing dapagliflozin to placebo in patients recovering from COVID-19, that there was not a statistically significant difference in the primary outcome. DARE-19 will also be presented at ACC. Next at ACC, heart failure therapy. Now, much of heart failure therapeutics focuses on medical and device therapies. Trials enroll really healthy, ambulatory, mostly male patients. But that's not like the real world. Out here in practice, many or most of our patients with heart failure have comorbidities that limit their physical functioning. This is why I love the REHAB-HF trial. It's going to assess novel physical rehab intervention for older adults with acute decompensated heart failure. And the trial is going to measure, get this, no, not recurrent heart failure or CV death, but physical functioning. Kudos to that team, and I hope this trial shows benefit because there is more to heart failure care than mindless algorithmic titration of medications. Another preview, alcohol and AFib. Dr. Greg Marcus and his clever team at the UCSF will present a study looking at alcohol ingestion and AFib episodes. His team has previously published a small but elegant study earlier this year on the matter. Now, we know alcohol associates with AF events in populations, and Alex Voskobonik has shown in an RCT published in the New England Journal of Medicine that abstinence reduces AFib burden in patients who have AFib. And now work underpinning these observations is important, may also give clues to AF pathophysiology. Lest I remind you that despite the surge in AF ablation, none of us really understand the cause of this condition. Next, renal denervation. Ablation in the kidneys is making a comeback, and at ACC, we will hear more about the Recor Medical's Paradise ultrasound system, which was used in the Radiance Hypertension TRIO study. Now, this was a sham-controlled study of about 300 patients who had uncontrolled hypertension on 3 meds. The company announced months ago that it had met its primary endpoint of control of daytime blood pressure. At ACC, we'll hear the details. Remember that in 2018, the Radiance Hypertension SOLO study which used the same device and sham control design, studied patients controlled on 1 or 2 antihypertensive medicines or uncontrolled on 0 to 2 medicines, and it also produced positive results. Lancet published that study. The devices earned breakthrough device designation from the FDA for the treatment of hypertensive patients who are unable to sufficiently respond to or are intolerant of antihypertensive therapy. Now, already published from the ACC, big meetings often feature a handful of papers that were released early, and one of them that caught my eye was use of medicines that increase blood pressure. This was a group from Beth Israel in Boston, and they studied the prevalence of use of medicines that may increase blood pressure. Now, they used data from the NHANES longitudinal study, which is broadly representative of a U.S. adult population. This is about a middle-aged group, age 56, and nearly half of these patients had hypertension. Of all the patients with hypertension, 19%, nearly 1 in 5, reported using 1 or more blood pressure-raising medications, and about 3% reported using multiple meds that increase blood pressure. The most common classes of blood pressure-raising meds were antidepressants, 9%, nonsteroidals, 7.2%, and regular steroids, 2.2%. They also noted that predictive models estimated that stopping one of these blood pressure-raising medications could improve population hypertension control rates by about 5%. Of course, this sort of data isn't new. I learned about the cardiovascular dangers of nonsteroidals in the 1990s. Our chief of medicine at the time was very interested in pharmacology. But I still think it's worth mentioning this because my thinking on this matter has changed. Yes, of course, clinicians should always be aware of blood pressure-raising meds and reduce or stop them when we can. There are a lot of patients on nonsteroidals that would do fine on acetaminophen. And as for antidepressant meds, it's also reasonable to assess for what indication that drug is being used. I've had to do this often in my long QT patients, and I've been surprised how many patients take antidepressant drugs for non-depression-like symptoms and are able to come off them. Where my mind has changed is that nonsteroidals and antidepressants sometimes allow patients to live more active, fuller lives. Say, patients with arthritis, for instance. And for them, the probabilistic increase in risk may be worth it. So I'm no longer an absolutist about these classes of drugs. Now to some non-ACC news. There is more good news about the drug Finerenone. Finerenone is a first-in-class and it's investigational but non-steroidal selective mineralocorticoid receptor antagonist, or MRA. It acts like spironolactone and eplerenone, but without the steroidal side effects such as gynecomastia. In 2020, in a large RCT Fidelio DKD trial published in New England, the drug lowered the risk of CKD progression, which was the primary endpoint, and also lowered CV events, which is the secondary endpoints, versus placebo in patients who had type 2 diabetes and CKD. Now, as part of the regulatory approval process, there is another trial called Figaro DKD. Here the endpoints are switched with major adverse cardiac outcomes as the primary and prevention of renal progression as the secondary outcome. The drug maker, Bayer, announced in a press release that Finerenone significantly reduced the composite risk of time to first occurrence of CV death or non-fatal CV events, such as MI, stroke, or hospitalization for heart failure. They also noted in his press release that Figaro DKD included more patients with earlier stage CKD and type 2 diabetes compared to the Fidelio DKD study. Finerenone is under review at FDA. The press release is all we have. Obviously, we need to see the details of the paper and presentation, but I really think we'll have a new and novel MRA on the market pretty soon. The final topic today is on ethics and professionalism. Multiple authors representing the AHA and ACC have published a long document on ethics and professionalism. I'm always a little perplexed about these sorts of efforts. Ethics is defined as moral correctness, and to be moral, of course, is to be concerned with the principles of right and wrong behavior and the goodness or badness of human character, or to hold or manifest high principles for proper conduct. Now, this document is finely written, and there is absolutely nothing in it to disagree with. And I may be wrong, and please correct me if I am, but I don't really see any need for a guiding document, nor do I think the morals of a cardiologist should differ from a worker in a factory or a carpenter. There is right behavior and right thinking, period. Right behavior includes studying like crazy to become the best doctor you can be. Right behavior includes listening to your patients, explaining their condition, not scaring them to death, and treating them with the therapy most appropriate for their situation, guided by evidence, but also judgment. Right behavior means respecting their privacy, always. Right behavior also includes having the humility to know that but for the grace of God go I. We are all imperfect beings, sinners, if you will. Right behavior means being kind and empathic to your colleagues. This is straightforward. Right behavior means being honest about your billing, conflicts, peer reviews, research. Honesty is super straightforward. Of course, these are all lifelong challenges, and the aim is to keep getting better. I think about these things often on my bike ride to work each day. Now, as for professionalism, I looked it up, and it said, quote, having the competence or skill expected of a professional. Now, being a doctor isn't as hard as rocket science or statistics, but it does require attention to detail, humility, dedication, and practice. Lots and lots of practice. By being good at our craft, we help people, and this makes the world a much better place. Indeed, that is what gives this job so much meaning. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, it really helps just to take a few seconds to give us a rating or write us a brief review, because that helps other people find us. I'll see you next week, and I'll have an ACC review next Friday. Until then, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.